Chronic actinic dermatitis, or CAD, is a fascinating yet challenging photodermatosis that we, as dermatologists, encounter. It is a rare, persistent condition where the skin develops an abnormal sensitivity to ultraviolet, UV, and visible light. While CAD is primarily seen in older males, it doesn't discriminate and can affect individuals of all genders and ages. It falls under the spectrum of idiopathic photodermatoses, alongside conditions like polymorphous light eruption and actinic prurigo. The hallmark of CAD is its relentless, eczematous lesions, which stubbornly appear on sun-exposed areas. These lesions are often accompanied by abnormal results on phototesting, reflecting the skin's hypersensitivity. This unique combination of clinical and diagnostic features sets CAD apart as a distinctive, albeit enigmatic, condition. Etiology: understanding the cause of CAD is akin to piecing together a puzzle. The exact mechanism remains elusive, but evidence points to an intricate interplay of genetics, immune dysfunction, and environmental factors. Genetic factors, possible associations with specific HLA types hint at a genetic predisposition. A family history of photodermatoses or atopy may increase susceptibility. Immunological dysregulation. At the heart of CAD lies a T-cell-mediated hypersensitivity reaction. Langerhans cells and CD8 cytotoxic T cells are hyperactivated, driving the inflammatory process. Environmental triggers, prolonged or intense exposure to UVA, UVB, and sometimes even visible light serves as the primary environmental trigger. Photosensitizers, such as medications like thiazides or quinolones, and certain chemicals found in sunscreens or fragrances, exacerbate the condition. Comorbidities. CAD often coexists with allergic contact dermatitis, atopic dermatitis, or airborne contact dermatitis, creating a complex clinical scenario. History. The history of a CAD patient is a journey through progressive photosensitivity and its triggers. Onset. Symptoms usually develop gradually, often without a clear precipitating event. There may be a history of new medications, sunscreens, or occupational exposures. Symptoms. Persistent pruritus or a burning sensation is common. Patients describe chronic eczematous lesions that worsen with sunlight exposure. Seasonal variation. Symptoms peak in spring and summer due to increased UV exposure. Social and occupational history. A history of outdoor occupations or hobbies often reveals prolonged sun exposure. Exposure to topical agents or airborne allergens adds another layer to the diagnostic complexity. Clinical findings. Cutaneous manifestations. Eczematous plaques, thickened, erythematous lesions dominate sun-exposed areas like the face, neck, hands, and forearms. Lichenification, a sign of chronicity in severe cases. Photosensitive distribution. The lesions are sharply demarcated at clothing lines, sparing shadowed areas like under the chin and behind the ears. Non-cutaneous findings. Some patients report systemic symptoms such as fatigue or malaise during flare-ups. Chronic scratching often leads to secondary bacterial infections, complications. Repeated scratching results in post-inflammatory hyperpigmentation. Secondary infections further compound the condition. How to diagnose? Diagnosing CAD requires clinical acumen combined with investigative precision. Clinical diagnosis. A thorough history and physical examination highlight the photodistributed nature of the condition. Phototesting. Phototesting reveals a marked reduction in the minimal erythema dose, MED, for UVA and UVB. Sensitivity to visible light may also be detected. Patch testing identifies coexisting allergic contact dermatitis. Common allergens include fragrances, sunscreens, and topical antibiotics. Skin biopsy. Histopathology typically shows spongiotic dermatitis with lymphocytic infiltrate and keratinocyte necrosis. It helps confirm the diagnosis and rule out differentials. Differential diagnoses. The condition must be distinguished from photoallergic contact dermatitis, polymorphous light eruption, actinic prurigo, and subacute cutaneous lupus erythematosus, SCLE. Management. Management of CAD is multifaceted, aimed at reducing UV exposure, controlling inflammation, and addressing triggers. 1. Non-pharmacological measures, photoprotection, broad-spectrum sunscreens with SPF 50 and UVA/UVB coverage are essential. Protective clothing, hats, and sunglasses offer added defense. Patients should avoid peak sunlight hours between 10 a.m. and 4 p.m. Lifestyle modifications, limiting outdoor activities and avoiding known photosensitizers are crucial. 2. Pharmacological therapy. Topical treatments, potent corticosteroids, like clobetasol propionate 0.05%, for acute flares. Calcineurin inhibitors, such as tacrolimus 0.1% or pimecrolimus 1%. For long-term use, systemic treatments, prednisolone at 0.5 to 1 mg/kg/day for acute severe flares, tapered over 2 to 4 weeks, immunosuppressants like azathioprine, 1 to 2.5 mg/kg/day, mycophenolate mofetil, 1 to 3 g/day, or cyclosporin, 2 to 5 mg/kg/day, in resistant cases, antihistamines, e.g. cetirizine 10 mg per day, hydroxyzine 25 mg at night, for pruritus, phototherapy using narrowband UVB or PUVA for desensitization. 3. Advanced therapies, biologics, dupilumab at 300 mg subcutaneously every 2 weeks for refractory cases, omalizumab for severe atopy-associated CAD, experimental treatments, Janus kinase inhibitors, such as tofacitinib, show promise in resistant cases. 4. Management of coexisting conditions, treat allergic contact dermatitis with allergen avoidance and appropriate patch testing, manage atopic dermatitis with emollients and steroid-sparing agents. Treatment algorithm, mild disease, topical corticosteroids, emollients, and antihistamines. Moderate disease, add calcineurin inhibitors or systemic corticosteroids, consider phototherapy. Severe or refractory disease, use immunosuppressants or biologics like dupilumab or omalizumab. Conclusion: chronic actinic dermatitis is a complex photodermatosis that demands a meticulous, multidisciplinary approach. By combining clinical expertise, diagnostic precision, and tailored treatment strategies, we can improve outcomes and quality of life